we go. Hi, everybody so far that's joined. Thank you very much. We'll just leave it a minute or two before more people to join in. Okay. Okay, so I'll do a little bit of an introduction of our speaker today. So I'd like to welcome Fran Ives, who is the Chartered Human Factor Specialist and the President-elect of the Chartered Institute of Ergonomics and Human Factors. And Fran will be talking today on human factor support for innovators. So over to you then, Fran.
Great, thank you. It's great to see everyone today. So as Andy has said, I am the Chartered Human Factors Specialist at Health Innovation West Midlands. And my aim really over the next sort of 30 minutes or so is to provide a bit of an introduction to human factors and how it can be applied to innovation. So in the time that we have, I'm going to try and keep it fairly high level today and give you an overview of human factors, why it's important to be considered in innovation, and specifically when it comes to thinking about the design and the development of devices. Excuse my very old laptop, it's obviously taking a time to wake up today. There we go. So for those who are new and relatively unfamiliar with Health Innovation West Midlands, just a very quick introduction. We're one of 15 regional health innovations, and we're really the innovation arm of the NHS. And our mission is to bridge the gap between healthcare challenges and innovative solutions, ensuring that transformative ideas reach the frontline care more quickly and more effectively. As I said, we're one of 15 innovation networks across England, and together we hope to really strengthen local healthcare systems, foster economic growth, and really ensure that anyone and everyone benefits from health innovations that are coming out. So it's a very exciting landscape to be part of. So I'm going to go right back to the beginning, right back to basics, and start with which term do we use? The term human factors means different things to different people. And certainly over the course of my career, I've been known as an ergonomics engineer, a human factors engineer, an ergonomics advisor, and now I'm a human factors specialist. So there can be confusion over which term we use and whether the terms mean the same things. So the term ergonomics tended to be used in professional practice in the UK from the 1950s onwards, whereas the term human factors was predominantly used in America. And over the years, the two terms have harmonised. And so in most non-English speaking, whilst most non-English speaking countries still use the term ergonomics, the English speaking world tends to use the two terms interchangeably. In the UK, we have the UK Chartered Institute of Ergonomics and Human Factors. That institute uses the terms interchangeably, and that's what I will do today. However, in healthcare, we tend to use the term human factors more. So that's the one that I will try to use more consistently today. So in essence, interchangeable terms meaning pretty much the same thing. But what is ergonomics and human factors? As with everything, there are numerous definitions across the world, and some of them are very wordy. This one is one I tend to use because I feel it's relatively nice and succinct. So the definition says that ergonomics and human factors is a scientific discipline concerned with the understanding of interactions amongst humans and other elements of a system. So ergonomics in human factors is a profession, and it's a profession that applies theory, principles, data, and methods to design in order really to optimize human well-being and overall system performance. So one comment that human factors specialists hear time and time again is, well, human factors is just common sense, isn't it? But if you've ever struggled with confusing door handles, fiddly microwave controls, or very frustrating shower settings, you'll know that common sense isn't always so common. If you're in someone's house and they ask you, oh, just stick that in the microwave for 30 seconds. I don't know about you, but I panic and freeze thinking, oh my goodness, how do I use this microwave? Yeah, I feel like I'm a fairly competent microwave user at home, but change the environment, change the machine, change the settings, and I can often be floored by what is a relatively common and simple piece of equipment. The idea that human factors is just obvious design work often, I think, really reflects a misunderstanding of what human factors is as a scientific discipline and what it actually involves. It's not just about guessing what feels intuitive. It's a scientific approach to designing tasks, to designing equipment, environments, and systems that really aims to truly match human capabilities and limitations. And at its core, human factors blends insights from physical, biological, social, and engineering disciplines. It's not always as straightforward as it might seem. So, for example, before I came to healthcare, I spent some time in the nuclear industry. So there, some of the tasks that I did were around looking at design of control panels used in nuclear power station. So if we think about designing a control panel in a nuclear power station, we can think, well, actually, we also design control panels in hospital environments. For example, a control panel for an ultrasound machine. And while both might seem similar and might use similar design principles like clear labeling, button placement, the context in which those two pieces of equipment are used are completely different. In a nuclear power station, the environment is highly controlled and it's pretty predictable. But in healthcare, we have patients that we add into the mix. They themselves create huge amounts of variability. We have very different environments. We have a lot of different staff dealing with very changeable and perhaps sometimes unpredictable situations. And all of these contribute to very different safety concerns. So this makes each design challenge absolutely unique, and it means that unfortunately we can't always use a one-size-fits-all approach. So it really is important to remember that good design often goes unnoticed. So when you think about something that works smoothly, we rarely stop to appreciate it. If you think about an iPhone, for example, many people will just be able to pick it up and navigate it quite intuitively without having to read a lengthy user manual. So you could ask yourself, is that common sense? Or is that iPhone the result of some quite careful planning, extensive research, and thoughtful design? So next time someone says, well, human factors is just common sense, do remember that behind every seamless experience, there is that huge amount of planning, that testing, and that refining. You know, human factors isn't just about making things look nice. It's about making systems work well for real people in real environments. So I'm going to put a big cross through this human factors is common sense. So things can sometimes go wrong. And sometimes we can not always foresee things going wrong. Now, this is an example of a ventilator that was fairly commonly used in COVID. And I'm not actually going to show you the front of the ventilator because that's not the bit that I'm interested in here. What I'm interested in is the back of the ventilator where there is an on-off switch, which is in the middle of the red circle. Now, this is you know, an area that's really interesting, because the first thing I notice about this picture and that on-off button is the fact that there's a clear perspex swinging sort of protective screen there. And that to me, I mean, I don't know, but that to me sort of says that something was added later on as a result of identifying how vulnerable that on-off switch could be. So if the machine is turned off, then when the button is turned to power up the machine, it will take about 2 minutes to resume ventilation. If, however, just next to that, the plug is removed, the emergency battery power will kick in straight away. So at some point, I'm guessing it must have been realised that actually the button, the on-off button, could be pressed accidentally, causing the machine to turn off and then causing that 2-3 minutes delay in ventilation being activated. So I'm guessing that as a result of that, they added this perspex swinging cover to protect the on-off switch. But interestingly, what was noticed was that that swinging cover could easily get moved by simple tasks such as moving the curtain to the bed space back and forth. And by that curtain just catching the perspex cover, it could leave the on-off button exposed. And it was observed that this was happening by all sorts of people, including domestics, people going into the bed space who had absolutely nothing to do with the ventilator, but were going in perhaps to clean or do some tasks with the patient. And it was leaving the machine quite vulnerable to being turned off. So this is just a really quick example of why it's so important to think about human factors and think about human factors at the design stage, so that we're not having to add things on retrospectively, such as this perspex cover. So work as imagined and work as done is a concept in human factors and system safety that's often discussed. And in particular, it's described very nicely by psychologist and human factors expert Stephen Shorrock. And it really goes to highlight how, in order for us to truly understand human work, we need to look beyond our work as imagined. Work as imagined is a term that refers to the way that we think work is undertaken. And it's usually what people such as designers, engineers, managers, regulators, policymakers work on. It's our mental model of how we think work is being undertaken. So this might include maybe some design assumptions on how we think a device will be used. It might be us assuming that various procedures and protocols are actually used. It might be thinking that various checklists that have been put in place are actually used. Now, our work as imagined can be based on all sorts of different things. You know, maybe we are thinking back to when we did that particular job quite some time ago. Maybe we've done a similar role elsewhere in a different organisation. Maybe we've worked alongside the people that we're considering. So we know a little bit about what they've done from observation, but we haven't actually done the work ourselves. So work as imagined can give us quite a lot of information about what people do, but it's not going to give us the whole picture, because our work as imagined information might be out of date, especially if we're basing it on us doing work 20 years ago, particularly if we're basing it on how we know work was carried out in a different organisation. So it will tell us part of the picture, but it won't tell us everything. Work as done is the way that actual tasks are performed by real users in the field. It really demonstrates the messy reality of work. That nice linear picture that we have in our minds of how people undertake work is often shattered when we go and observe work and see work as done. We see the time pressures, the high stress environments, the unpredictable patient needs, the ever-changing clinical situations. Here we get to see all of the workarounds and the shortcuts that staff have developed to save time. And we understand much better when we observe people working what that cognitive overload looks like, the fatigue and the stress, and how that might be impacting the decision making that people are undertaking. So observing work is absolutely crucial to see how things are actually done. But again, it doesn't give us the whole picture. Work as prescribed is what things like our SOPs, our procedures, our protocols are telling us that work should be, how work should be undertaken. And they're often held up as the gold standard. And when things go wrong, very often people will go back to those procedures. And if they identify any workarounds or any deviations from those procedures, it will often be used as a means for blame. Well, that person didn't follow the procedure. So that is why X, Y, or Z happened. So work as prescribed gives us quite a lot of information about how a task is thought should be undertaken. But how often have we looked at a procedure and found that it's perhaps out of date? It's talking about a piece of equipment that maybe we don't use anymore. It's talking about a working environment that we moved from 3 years ago. Work procedures are often really complex documents. They're often really big and heavy, and the piece of information you want is on page 366, and actually you've only got a few minutes to find the information that you need. So inevitably, work as prescribed doesn't always reflect what actually happens, and that can be for many reasons. Work as disclosed is what people tell us. So I often, in my work as human factors specialist, ask people about their jobs. And it can be really interesting to listen to people and listen to what they're telling you. And if you think about how you would describe your own job, the way that you described it would probably change depend on your audience. So think about whether your description would change if you were talking to your manager, if you were talking to a friend, if you were talking to a colleague, a politician. Think about how what you say to people might change depending on the particular agenda that you may or may not have. So work as disclosed can give us a really honest and really raw insight into what people do, but people can often be quite choosy about what they tell you. So in order for people to understand what actually happens, it's really important that we look at all of those things. And so when it comes to people working on innovations and developing innovations, it's hugely important that you take the time to understand what is actually going on. I was working with an innovator recently, and we were talking about what the barriers might be for the innovation that we were considering. And this individual had spoken to some of the managers and had got a fair idea, but really felt like there may be some more gaps, there may be some more barriers that we haven't considered. And I said, why don't we just go and speak to the staff? Why don't we go on site and just ask them what they think and get the workers disclosed from the people who are actually doing the work? And by actually being in their environment, we could get a much better idea of work as done. And the amount of information it gave us was absolutely phenomenal. So if you are collecting information about what goes on and how your innovation might fit into that, do make sure that you collect that information, that knowledge in a variety of different ways. So if you are in the midst of developing an innovation, or if you are thinking about developing an innovation and human factors is really new to you, it might be really difficult to know where to start. What do I do? I'm not a human factors specialist, so how on earth can I navigate my way through this? So I'm going to give you sort of 5 headings and 5 sort of things that you could think about doing and start incorporating into your work, just to give you a bit more information about the users, the type of people who will be interacting with your innovation, the sorts of tasks that they might be doing, and how you can maybe test whether your innovation is going to be up to scratch. So user research is really a foundational part of any sort of medical device or innovation design, because it helps you to ensure that that final product is safe, it's effective, it's user friendly, and it involves understanding the needs and also the limitations, the environments of all potential users. Now, when we talk about users, one of the things that people often overlook is the full range of users that might be relevant here. So it's really important to actually stop at the beginning and think about who your users might be. We often think about the most obvious ones, so they could be patients, they could be staff, but we don't necessarily think about the people who are maybe behind the scenes. So sometimes if it's a hospital device or innovation, it may be that we have some more admin and clerical type people using it. We might have some ward clerks or some ward admins. We might have some informatics people. And it's those sorts of people that are very often forgotten when we think about users because we don't go beyond the more obvious ones. So really try to think about who your users will be and try to understand them. So for example, if you're thinking about an innovation that's going to be predominantly used by patients, think about the needs that they might have. They might want something that's very easy to use. They might want something that's comfortable, it's safe. They might want some psychological reassurance from using it that they're doing the right thing and that they're using it correctly. Using devices with patients can also obviously bring some challenges. They will have limited medical knowledge. They may, depending on who they are and what their conditions are, may have physical limitations. They may have anxiety over using these pieces of equipment, or for some patients, there may be an element of cognitive impairment. So an example of something a patient might be using would be a wearable glucose monitor. So here the drivers might be something that's comfortable, discreet, and easy for a patient to manage without frequently feeling like they need to call for assistance. A clinician may have different requirements, so their needs may be more around speed, accuracy, reliability, and ease of integrating that device into their existing workflow. The challenges they will very likely have will be high stress environments, they'll most likely be multitasking, and you will have a variety of people with differing levels of training, knowledge and information on the device that you're considering. So there might be in a hospital, we have huge numbers of infusion pumps of different designs, different makes. So how do we make sure that the infusion pump that we're designing has got intuitive controls, it's got clear feedback, and it's giving us rapid information if we need it in case of emergency situations. We might also have caregivers who are the users. And here, a bit like patients, they might want simplicity. They might be wanting really clear instructions and features that are going to really help reduce the risk of errors. Their challenges might be more around emotional stress. If they're caring for somebody, there's probably some physical fatigue going on, and they're very likely going to have limited medical knowledge. So the sorts of equipment they might be using is maybe some kind of home dialysis system, and there we'd very much be wanting to have clear step-by-step guides and also very clear safety alerts. When we're thinking about our users, we also very much want to think about the use environment. So devices that we're considering could be being used in clinical settings, but even they vary. So we could have ward environments, ICUs, emergency departments. So here we'd want to think about, a piece of equipment that were really robust, things that could be cleaned appropriately and stand up to hospital infection control teams. Home devices, if we think about devices used in homes, again, with their design, they've got to be simple and reliable. They've got to be suitable for use in non-clinical conditions. So there might be different temperature changes, there might be different floor surfaces, we might be wanting to move a piece of equipment up and down stairs. And we might have some devices that are going to be used outside or mobile, so maybe wearable or portable devices. So here we want to be thinking about things that are maybe really compact, things that are durable, and things that are easy to use on the go, things that can be used outside as well as inside. So how do we get this information about our users? So we can get this in a variety of different ways. We can conduct interviews and focus groups, so we can have conversations with people and really understand the things that work for them currently, perhaps what their pain points are and their unmet needs, to try and identify, what's important to them. That is our sort of, part of our work as described. We can observe people in the actual working environments, their actual home environments, and that will enable us to uncover some challenges that maybe they actually wouldn't think to tell us. Not necessarily that they're withholding that information, they just didn't think that that was something worthy of note, or it's something they're so used to, they just get on and do it. So doing that user research really helps us to collect together a record of what our users, who they are, what their needs are, and what their requirements are. And that can give us some really valuable information. So the next thing we can think about then, once we've got that information, is really trying to think about task analysis and workflow mapping. So what we mean here is task analysis is all about breaking down each step that a user will take to operate an innovation medical device safely and effectively. And by breaking the process down step by step, it helps us to identify potential sources of error, and it helps us to really streamline the workflows, and really to help us understand how best we can make that device align to the real world needs of our users. So by thinking about breaking down those tasks, we can hopefully identify and mitigate points where user errors might occur. We can hopefully identify areas where that critical tasks are going to be taking place. And this information can really help to inform our design. And we can change design much more easily when we're at the sort of the pen and paper stage than once we've got a fully functioning prototype or indeed product. So it's really important to develop use scenarios. So developing realistic use cases to help guide our design decisions. So this is a really important part because not only can it help guide design decisions, but it can help validate user needs, and it can help again to identify potential usability issues early on in the process. So some examples of use scenarios might be, say you're thinking about a smart insulin pen for diabetes management. So you could create a scenario which could be a female patient, 45-year-old professional with type 2 diabetes, and they need a reliable, easy to use insulin delivery device. This person might be juggling a busy schedule, they might travel frequently, they might also be someone who struggles to remember their doses. So for this person, a use case could be, a normal use case could be somebody who doses before breakfast using a one-touch button and with a clear digital display to verify the dose. But let's also think about when that person might be using their device in an emergency situation. So for example, if this patient experiences hypoglycemia, the pen's companion alert would alert her to adjust the dose based on real-time glucose readings. So here we've already got a normal use scenario of when they're using it day in, day out, but also what an emergency use scenario might look like, because they could be very different. We might also want to build into that use scenario maintenance. So how often the insulin cartridges and batteries are changed, and how they know that they need to be changed. Are there any app notifications to help them with that? So by creating these use scenarios, it can really help designers and innovators to think about what's important, to think about things like intuitive controls, clear feedback, and hopefully seamlessly integrate it into any sort of other workflows or scenarios that might be relevant to them. So it's really interesting and exciting when you get to the prototype staging, because this is where you can actually sort of take those paper plans and take all that research and actually create a prototype, which is starting to give you a little bit of a feel for what your end product might look like. Now, prototyping can just be a very simple mock-up. I've made prototypes out of cardboard and masking tape for very early stage. It's very quick and cheap and easy to do. So prototypes don't always have to be, really expensive, so high fidelity. But when you do your prototyping, you're then able to do some usability testing. Now, there's two different types of evaluations that we can think about. So formative evaluations are conducted very early on in product development cycle, and it's very much when a product or device is still in the design and development stage. And this early formative evaluation can really help to inform the product's design. So the goal here really is to detect any early issues and try to eliminate those problems before you get to the point of having a fully developed product. So these user testing, these formative evaluations tend to be quite qualitative in nature, and we can see how users are sort of experiencing the design. We can see where they get stuck. We can hear what they're saying, the frustrations, the expletives potentially when they're using them. And the data we can collect in these formative evaluations can be really, really useful and very interesting. It may be that you end up carrying out a number of these as you refine the design, but that's absolutely fine to keep repeating these. And then the last of the fifth steps is to really think about risk management. So risk management integration is a really critical aspect of medical device innovation design. So it's really trying to ensure that safety and regulatory compliance has been achieved. So here we want to really think about identifying potential use related hazards. So here, this step is really thinking about proactively identifying potential hazards that could arise when people are using the device. So in order to identify these, we really need to have a deep understanding of the device's users, the operating environment, and the clinical context in which it's being used. So we can collect that information, by doing things like user observations, that task analysis, to really try and understand what those risks are. And that'll lead us then on to trying to understand the severity and the likelihood of those risks. And then we can move on to, once we've identified the risks, understood sort of how big they are, we can then think about implementing design controls to minimize those risks. So we could do a whole other webinar on IEC 62366. So I'm just going to give it one slide today, just to put it on your radar if it's not already there. So IEC 62366 is an international standard that covers the application of usability engineering to medical devices. So it's really the standard that helps manufacturers incorporate human factors into their design process. And to ensure that the medical device or the innovations that they're producing are effective and safe for their intended users. So it lays out a standardized step-by-step process for really trying to analyze, identify, and then develop and evaluate the device for its usability. And many of the steps are really sort of what I've broadly covered today. So the steps involved in IEC 62366 are things like identifying your intended users, identifying the use environments, identifying use-related hazards, identifying the critical tasks, developing and implementing risk mitigation and control, and really validating user safety and user effectiveness. So there's a whole potential other webinar to explore this particular area, but I just wanted to sort of bring it up to really put it on your radar, and really understand and appreciate that usability engineering and that validation of devices is really important. So I'm going to leave you with these questions, which were posed by Professor Sue Hignett from Loughborough University a few years ago. And I think they're a really nice set of questions to ask when you're thinking about human factors in any kind of work setting. And the questions that you can ask yourself are, can this person, be it staff, patients, caregivers, with this training or information, do these tasks using this equipment or service under these conditions? And by asking those questions, it gives you sort of a quick feeling for whether human factors has been considered. Because if you're answering no to those questions, I think really it's an indication that more consideration could be given to human factors in whatever we're doing, designing, or changing. So I've hopefully left a few minutes for questions. There's also a QR code there on the screen, which will guide you to a feedback form. And we're also really keen to see if there are any particular topics or improvements that we can make. There will be more webinars in this series, so it's a good opportunity to make suggestions of other things that you would like to cover or listen to. So I will hand
Thank you,
back to
Fran.
Andy.
Thank you, Fran. We have a couple of questions. The first question we have is, does your role typically involve using psychology or behavioral science frameworks too? If so, do you have any that you commonly refer to? That's from Olivia.
Okay. Human factors can be, it can very much cover behavioral psychology, communication, things like that. In terms of any particular frameworks, it would very much depend on what we were doing. It's not particularly my area of expertise. A lot of human factor specialists come from a psychology background. And so I tend to sort of more lean on those psychology colleagues for those specifics. But yes, human factors is very much about communication, behaviour, cognitive decision making, and things like that. Is there a specific scenario that you have in mind, or is it just a general question?
I think there's another, and go on, Olivia.
It was
Hi,
more of
Olivia.
hello, thank you so much. It's a very interesting talk. It was more of a general question because I work in innovation and I'm not a behavioral scientist myself, but I do work with
Okay.
behavioral scientists, and they often use frameworks to understand behavior. And a lot of what you described sounded like you really need quite a deep insight into how people think and what motivates them, etc., to allow them to use the device or whatever innovation properly. So one framework that they often use is, for example, the COM-B framework, where you're asking are they able to use it? What's their motivation? Are there opportunities? What is the environment like? So a lot of similarities to what you've described, but really formalized. So I was curious to see how much of that thinking tends to be used by you, or how, if you work in teams, etc. But I think you've answered some of that.
Yeah, okay. Yeah, thanks for that. Are there any others, Andy?
No, I think that the second part of the question was from Olivia as well. I think that was it was just for do you tend to focus on asking or observing as well?
Human factors is a great science for those with a curious mind. And when I first came into healthcare, I did worry that not coming from a healthcare background would put me at a disadvantage. But actually, I realised quite quickly that there were lots of advantages for me not knowing very much, because I could ask what were the seemingly obvious questions. So, oh, tell me more about why you're doing that. And sometimes asking those questions and getting people to think about tasks that they do very automatically, but in a different way, makes them stop and think, why do we do that? Or do you know what, that maybe isn't the best way to do it. So going in with no assumptions means that you can challenge some of the norms that have been passed down. And sometimes they're the most interesting questions to ask.
Thank you, Fran. Are there any more questions? Feel free to either unmute and come on and ask, or you can place it into the chat. Cool. Well, I've also added the QR code into the chat. Your feedback will be much appreciated, so we can obviously bespokely tailor these as we go forward and learn from each one. So if you do take the time to fill out the feedback form, that would be much appreciated. I do see somebody. Thank you, Verity. Really interesting. Thank you. So we will pretty much call this to a wrap. Thank you all for joining today and taking the time out of the lunch period, and look forward to our next webinar, which will be in July, and we'll be advertising that via LinkedIn, etc., and internal process. So have a look forward to the next one. Thank you all very much for joining. Thank you, Fran, for taking us through.